Welcome all of you to this oral plenary session, Best of the best abstract selected. We'll start with the first abstract by Satoshi Hirano from Japan on adjuvant chemotherapy, Gemcitabine versus observation in resected bile duct cancer, a multi-center randomized clinical trial in Japan. Dr. Hirano, the floor is yours, please.
Thank you, Chairman. Good morning, ladies and gentlemen. I'm Hirano from Hokkaido University, Japan. And it is a great honor for me and for our group to be given this opportunity to present the result of our study. I would like to present the result of randomized phase 3 trial of Adjuvant Gemcitabine versus observation in resected bile duct cancer. It was conducted by the Bile Duct Cancer Adjuvant Trial BCAT study group in Japan. The study was sponsored by Nagoya Surgery Support Organization, funded by Eli Lilly. The company had no role. It is well known that the outcomes of the bile duct surgery are very poor, and the 5-year survival even after the curative resection is 30% in Japan. Some studies reported that gemcitabine showed response rate of 7 to 18% in unresectable or metastatic bile duct cancer with a mild toxicity in Japanese patients. Meanwhile, adjuvant gemcitabine prolonged early in the 2000s. The ONC001 study present the adjuvant gemcitabine prolonged survival in resected pancreatic cancer patients. This result derived us to do this trial. The objective of BCAT trial is to investigate the effectiveness of adjuvant gemcitabine for patients following the potential curative surgery of the bile duct cancer. This study was two-armed, open-label, multicenter phase 3 trial. Patients with historically proven hiatal and distal cranio who underwent macroscopically curative resection. The patients divided randomized in 2 groups, observation only and gemcitabine administration. The gemcitabine was dosed 1,000 milligram per milliliter once a week for 3 weeks, and followed by the 1-week break. It continued 6 cycles. The primary endpoint of this study was overall survival, and the secondary were relapse-free survival, subgroup analysis, and toxicity. The patient enrolled in this study was the pathological size stage 3 or less, or R1 or R0 resection patient according to the UICC classification system 6th edition. The patient with ampullary or gallbladder cancer or interhepatic cholangio was excluded from the study. The 5-year for the statistics analysis, 5-year overall survival of the observation group were assumed to be 30% from the Japanese literature. When the hazard ratio of the gemcitabine group for mortality set to be 0.85, to achieve the 80% of power with a two-sided significance level of 5%, the required sample size was 300 with an event of 189. So we planned the final analysis will be performed after the completion of the 5 years follow-up. The enrollment period planned to 2 years, but it was extended to 16 months. Finally, 226 patients enrolled in this study, and from the 48 Japanese institutions. After of randomization, 188 patients in observation group and 117 patients in the gemcitabine group were determined as a full analysis set. After the exclusion of 2 patients from the observation group and 4 patients from the gemcitabine group, the safety analysis population was composed with 106 patients in observation group and 113 patients in the gemcitabine group. The patients' demographics and tumor characteristics are well balanced in both groups. The hydrocholangio was included in 45% in both groups, and pancreatic and hepatobiliary resection were the dominant surgical procedure in both groups. And the hepatectomy were performed in 50% in the entire cohort. The median weekly gemcitabine dose was 651 milligrams per square, and the median relative dose intensity was 82%. It was not different between the patient with hepatectomy or without. 53 patients discontinued gemcitabine due to that dose reduction over 40%, or patient refusal, and so on. Remaining 61 patients, I mean the 52% of the patients completed the protocol treatment, achieved the protocol treatment. Regarding the adverse event in the gemcitabine group, grade 3 or 4 hematologic toxicity frequently occurs. The neutrophil decreasing is most common, occurred in 58% and followed by the decreasing the leukocyte occurred in 29 patients. Otherwise, non-hematologic toxicity rarely occurred, and serious adverse event was not reported. This is the result of the survival analysis. You can see the overall survival of the after the median follow-up period of 80 months. You can see the 5-year survival, 3-year survival rate of the gemcitabine groups, 68%, and 5-year survival rate was 52%. At a glance, you can see there's no difference between 2 groups. Rather, very matched, completely matched, overlapped of each other. For the relapse-free survival, you can see there's no difference between 2 groups, and the 5-year relapse-free survival was very similar with 45%. And subgroup analysis for the nodal status, the N0 group has no difference between 2 groups. Also in node positive groups, there's also no difference between the groups. For the merging status subgroup analysis, R0 group has no difference between 2 groups. Also, R1 groups, no difference between 2 groups at all. There's some limitation of this in this study, and the first is termination of the recruitment before reaching 300 patients. It is due to the delayed enrollment of the patient, which resulted in the underpower of the analysis. But it must be the same with that when we collected 300 patients. Another limitation is unexpected high 5-year overall survival of 50%. It is influenced by the patient selection, in which the patient with metastatic artery resection or in hospital death was excluded from the study cohort. Recently, BILCAP trial was present the capecitabine administration for the adjuvant setting. The patient with capecitabine patient survived longer than the observation patient. It was achieved only in the per protocol population, not in the ITT. And this, the cohort of this study include a high rate of R1 resection and node positive and gallbladder cancer patients. Those are the limitations, I think. So it is a conclusion of the BCAT study. The adjuvant gemcitabine does not improve survival in patients with resected bile cancer. Last but not least, I would like to appreciate all the patients and the supporters, also the investigators and the teams. Thank you for your attention.
Okay, the discussion will be led by John Primrose. John?
There he is.
Yeah, okay. Can we activate that microphone over there?
Or you could come up here.
Okay.
Yeah, so thank you for your presentation. As we wait for John Primrose to come, it's obviously a disappointment that you didn't receive a result with the chemotherapy. Would you think you should give the chemotherapy before the operation?
This is a difficult question, but I think to improve the survival of this cancer patient, well, first the adjuvant therapy is first, and when the adjuvant therapy was built, so determined that some effective adjuvant therapy is determined. After that, we should do the preoperative trial for these tumors, I think.
Right. Well, thank you very much. Microphone closer to it.
Hello. Hey, hello. Dave Lamleden, over here on the right side. I have a question. And in your analysis, there was a high dropout rate in completion chemotherapy. About half of them had 6 cycles, right?
Right.
Did you do a subgroup analysis of that group that completed the completion chemotherapy and overall and disease-free survival versus those that didn't? Did you find their difference?
I'm sorry, I can catch your question precisely.
So in patient enrollment, there's about half of them that did the full cycle of chemotherapy, right? Half of them dropped out.
Yes, yeah. 52%.
Yeah. Did you do a subgroup analysis of that group on survival?
I'm sorry, we have never done that subgroup analysis for the full set of who achieved the full cycle of gemcitabine or not.
Because if they have completed the full cycle, maybe they do have an advantage of disease-free survival.
Okay, thank you. We're going to move on to Dr. Primrose.
Okay, so thank you very much for giving me the opportunity to comment on this excellent study. So until the last year or so, the adjuvant therapy of biliary tract cancer was essentially an evidence-free zone. But now there are 3 studies on which we either presented or published that gives us an evidence base on which to build our practice. Now, in the UK, in around 2005, we discussed running an adjuvant trial in biliary tract cancer, and we considered whether to use gemcitabine or capecitabine as the agent of choice. And for no reason that I think is particularly strongly scientifically based, the UK study elected to use capecitabine. And in fact, you've seen the overall survival curve from that study, which we presented at ASCO last year. Now, both our studies have taken about 10 years to complete, which is a very long time. I think the study that we've just seen presented here, and it's great that a big practice-changing randomized trial is presented at IHPBA. Now, the BCAT study is negative, but that doesn't reduce its importance because it adds to the evidence base in the area, and it enables us to move on to the next study. And we know what the result now is for capecitabine. We know what it is for gemcitabine, and so we know how we should go for the next study. Now, I've a couple of points to make and a question. As with BILCAP, the survival was very much better than we had expected. And I think you pointed out very nicely that the patient population that goes into an adjuvant trial is actually a very selected population, because it's only those who have the surgery and are well enough to have the chemotherapy that progress. I think the comment made earlier about whether you complete chemotherapy or not, I think is actually not relevant, because it's an intention to treat randomized trial. Exactly as within BILCAP, a number of patients did not complete all 3 months. And that is because it's pretty tough to go through a major biliary tract operation and then have chemotherapy. And inevitably, they don't all get through it. But I think it's not possible to pull out the ones that just completed and do analysis of those. That is not, I think, statistically correct. The question I have for you is that in BILCAP, we took all comers. So we took intrahepatic, we took gallbladder, we took hilar and distal. Now, I think we would now accept that all of these diseases are probably, on the molecular pathological point of view, slightly different. But you chose to look at just hilar and distal, and I'd be interested to know why you did that, because certainly we believe in BILCAP, we have got a lot of information out of including gallbladder and intrahepatic cholangiocarcinoma as well. And my last point is this, that we've both taken 10 years to do these trials. If we're going to move the field forward, we really need to do them quicker. And that's really a plea for really global collaboration in these sort of trials, so we can get them done in a few years rather than 10 years, and we can move on. So once again, thank you very much for your excellent study, which I enjoyed very much.
Thank you. Our patient enrolled in this study was not only the hilar, but distal, or both. And I think that these gallbladder and the cholangio bile duct and ampullary cancer is both, those are very difficult in the oncological biological phenomenon status. So I think we should study we should study, focus on the one cancer, but it takes many long time. You said 10 years or 10 years. So I think it is very important to do a global trial to find an appropriate chemotherapy after the surgery.